All right, so we are going to come down the home stretch with our final two discussions here for our critical care symposium. Thanks again to Dr. Marcolini and all of you interacting online, answering those questions that you had for follow-up with Dr. Marcolini. So any continued questions for her, just please put them in the chat. She is online answering those as we speak. So our final two discussions, two tough cases in critical care, the first of which is going to be really resuscitating patients with right ventricular dysfunction, a really challenging and really tough patient scenario. And to take us through those pearls and pitfalls is Dr. Lucas Sjeklocha. Lucas is a graduate of our UMEM residency program, followed by completion of critical care in our surgical critical care program through the Shock Trauma Center. He's currently an assistant professor in the departments of emergency medicine, along with the program in trauma at Shock Trauma. So he splits his time between emergency medicine and the surgical critical care and trauma critical care world. He's actually currently attending this morning in the SICU, so our thanks to his colleagues who are covering him while he gives us some pearls and pitfalls in resuscitating the right ventricle. Lucas?
All right, thank you for being here online. So I'm here to talk about resuscitating the right ventricle, which is a huge topic, a complicated topic, and I think an interesting one, as we'll see. I have no disclosures. Our objectives today are really to learn to recognize acute PH, learn to recognize RV failure, understand how it's something that's different than other shock states, and apply, in general principles, RV and pulmonary hypertension informed resuscitation to patient care. And a lot of times that can be a through the looking glass experience of doing the opposite of what you might normally do in a general situation. We're talking about not intubating a patient in respiratory distress, giving Lasix and trying to remove volume rapidly in patients who are actually hypotensive and on escalating doses of pressors. And so it's the sort of experience that can really feel like trying to find the calm in the storm. And part of my goal is to give you some confidence in principles in general in how to land that plane for these really sick patients. Because unfortunately, there is no good evidence, there is no stepwise process for being able to deal with this problem. And it's a diverse set of problems. The biggest disclaimer for this talk is there's a lot of scientific statements. There are few trials and guidelines, especially with high quality evidence. You know, the AHA, the European Society for Cardiology statements and pressors, inotropes get a class 2A or 2B recommendation at the best, even in patients in shock. We don't actually have great evidence that inotropes in shock, believe it or not, improve mortality. So this is a lot of expert opinion. It's practice variation, and a lot of the evidence you read in the literature suffers from what I heard once referred to as the Cochrane inversion, where you have more clinical reviews, more meta-analyses and systemic reviews than actual evidence, and the same articles keep getting written about the same evidence base, unfortunately. So why does pulmonary hypertension and RV failure matter? Well, it's a bad problem, and it's something that you'll see almost in the emergency department, often every day in critical care if you're looking for it. PH-related diagnosis and RV-related diagnoses account for about 1% of ED presentations. They have an 87% admit rate and double the inpatient mortality of the typical national inpatient sample. And they're also notorious for obviously causing cardiovascular collapse as well as arrests during procedures. And these set of problems is associated with a wide variety of diagnoses that we commonly see in the emergency department. Primary pulmonary hypertension, or what's so-called group 1 pulmonary hypertension or pulmonary arterial hypertension, is a relatively rare entity with specialized care. But chronic pulmonary hypertension, and these are the patients that are set up for acute RV failure, is not. Most common causes being left heart disease, especially worldwide. Chronic lung disease is another huge cause, especially in the US. Chronic thromboembolic pulmonary hypertension, or CTEPH, people who've had chronic PEs, is essentially a mechanical block in the pulmonary arteries. And then there are numerous causes due to unknown mechanisms. The left ventricular literature is a busy place. There are many guidelines. We have much higher quality evidence for what to do with left ventricular problems, with hypertension. But if we think about the difference between the literature for heart failure with reduced ejection fraction compared to our confidence for heart failure with preserved ejection fraction, for right ventricular failure in acute pulmonary hypertensive states, that busy place in the literature is really empty in terms of the evidence that's coming in. And so that means that we have to go back to the physiology lab. And without high quality trials to guide us, I think it's more useful to present you a set of principles and some pieces of data that I want to stick in your mind about when you encounter these patients, rather than just cases that say what I've done. I think applying the principles here actually matters, because that's what we're doing as intensivists. And I think that's how we make up what is going to be needed for any one patient on any given day. And so back to the physiology lab. So this is from the Visible Heart Lab at my alma mater, University of Minnesota. And this is the right ventricle. We see a lot in cartoon form, but the RV outflow tract on top, inflow and outflow. This is a complex geometry organ. It's got a complex shape and a complex function. And if you take it apart and start looking at it structurally, you see the LV is thick-walled, largely round, concentric, lots of overlapping fibers, and the RV has this complicated shape that's elaborated on top of the LV, thin-walled fibers that are more in a unidirectional fashion to give it this complex twisting shape to pump. And so if you would make some predictions just based on looking at this structurally, you'd think, okay, the RV is a volume-adapted pump. It's compliant. It can handle a lot of different venous return, and it's efficient. But the LV is stiff, it's thicker, it's higher energy, and it's adapted to deal with higher pressures. And that ability of the RV to be compliant and handle lots of different volumes is important for its function physiologically, but also sets it up for the failure that we're going to get more into. Because if you ask, why is the RV so important? We keep increasingly recognizing that RV failure is a big problem and has very high mortality associated with it. But how can a patient who has this physiology, this is a cartoon of a fontan, their right ventricular system has been disconnected from venous inflow and is actually used to pump their lungs. They have no right ventricle. All the perfusion through their pulmonary circuit is passive. So how is it that these patients are actually able to survive? Because the system in venous return is actually quite afterload sensitive, and that's really one of the failure modes of the right ventricle, is when there's any sort of afterload on that venous return and it can't be a passive conduit, that system that's normally compliant suffers from vasoconstriction, hypoxia, or other causes that we'll get into. And those causes of RV afterload are everywhere. So when the left ventricle gets exposed to higher afterload, this is a physiologic trial just artificially boosting blood pressure, you get some reduction in stroke volume, but for the right ventricle, that stroke volume gets dramatically reduced quickly after you get above a PA pressure of about 20, which is why part of the reason why a pressure of 20 is now the new standard for the diagnosis of pulmonary hypertension. And those causes of afterload are everywhere. Hypoxia is a huge one, hypercarbia, acidosis. The left-sided processes that we're concerned about, high intrathoracic pressure associated with intubation, lung collapse, alpha agonists, as well as blood clots and all the other classic things that we think about, like the crashing PE patient. And the complexity of actually getting these lungs recruited has consequences for how you resuscitate these patients, because it's not just a simple, the higher the pressure on the lungs, the worse the RV afterload. It actually depends on the degree of lung recruitment, and that becomes important for how to resuscitate these patients. The RV also has a more tenuous perfusion. There is less elaborated capillary networks. The RCA has fewer perforating vessels compared to the LV. And really importantly, the left-sided circulation gets a huge boost from the aortic root. All that coronary blood flow that's coming right after systolic ejection that goes down the left coronary, and then the left ventricle actually has moments in the cardiac cycle where it has no blood flow, it actually goes backwards as the heart's contracting. The RV is dependent on continuous flow throughout the cardiac cycle to get its blood flow, which means as you have higher filling pressures on the right ventricle or decreased systemic pressures, that RV perfusion is even more vulnerable. And this leads to what is described in a lot of different literature as the RV spiral of death. I happen to like this graphic from First 10EM as a nice sort of simplification of a lot of complex physiology. But often the mode of failure, apart from systolic function, really comes from the overloading of the ventricle. It dilates, it gets big, the pressures inside it shifts over and impinges the filling of the left ventricle, acting like a tamponade effect. Recognizing the failing RV, right? These symptoms are protean. It's as simple as dyspnea, especially with clear lungs, abdominal discomfort, signs of shock in general, especially when you can't isolate it to the lungs or to another easily identifiable problem. And there's diverse causes and acuity of onset, right? There's the smoldering CHF, there's the hypoxic, there are people with pneumonia, which is a common precipitant of RV failure, especially in your patients with chronic lung disease. And then causes of acute decompensation, such as your PE, MI, sudden lung collapse, and then general states of shock like post-arrest. Intubation and arrhythmia are also particularly common and challenging circumstances to deal with. And the lab findings themselves are protean. So to clue you into some things apart from just getting your history and physical, which I think is still actually the most important thing for these patients, recognizing that arrhythmia is a common precipitant. Many different ECG findings are described with varying degrees of specificity for RV dysfunction, but in particular, right axis deviation can clue you into acute or chronic RV dysfunction. Anterior ST depression clues you into an ischemic, struggling right ventricle, which is part of the reason it's a finding in particularly massive PEs or hemodynamically significant PEs. We know that S1Q3T3 is a non-specific finding, but also that the ECG is commonly normal. Chest X-ray is not as helpful, can provide a couple of clues. In particular, this large right heart border can be suggestive of increased pulmonary pressures and right atrial pressures. The lungs may be clear in a patient like a acute PE patient, but it may also clue you into the pneumonia or to the chronic lung disease that set them up for this problem. CT scans that we get so commonly can actually be really helpful in guiding some physiology, and there's presently many studies out looking at CT findings that actually clue you into cardiac function. And so the RV should normally be about 2/3 the size of the LV, but you can actually see cavity sizes quite readily on CT scan. And so in this patient who has a massive PE, you can see the RV is actually larger than the LV, the septum's flat, and that RV to LV ratio greater than 0.9 is very suggestive of RV dysfunction. And as you go higher on that ratio, it's much more specific. Septal flattening, reflexive contrast down the IVC is another potential ominous sign that you can see on CAT scan. It's actually the RV dilating so much that the tricuspid valve has opened up and is shooting contrast that has returned to the heart backwards down the IVC, and you can actually see it going up the hepatic veins. And then the RV hypertrophy can also be recognized in those patients, cluing you into a chronic process. So we just get the patient out of the donut of truth, and I have a tough act to follow with Dr. King's memes. The best joke I could come up with about ultrasound is calling it the eclair of truth rather than donut of truth, which has no chance of standing up to what Dr. King's been able to present. But early echo is your friend here, and I think the most sort of important takeaway in resuscitating these patients is the information you get on echo is going to guide your management. It's how you communicate with potential consultants. It's how you know whether your treatments are working. And if you are just adopting echo in your emergency department and you've started getting gestalts, I encourage you to work on getting your game up a little bit and start trying to get things like TAPSE, and potentially, if you're very confident in this, working your way up to using Doppler to look for things like tricuspid regurgitation. But probably the most important piece of information about general RV dysfunction that's reliable between providers is the TAPSE of less than 17 millimeters. Less than 10 being severe dysfunction, and that's a common way to be able to communicate with consultants and with each other and to track over time. To orient people, we have an echo here. This is a normal heart. You see even chambers, you see normal chamber sizes. There we go. And you see the lateral annulus of the right ventricle is smartly moving up towards the apex. In the struggling right ventricle, this is a patient who had a massive PE. You see the dilation of the RV, it's greater than the size of the LV. The tricuspid valve down by the pointer is just coming together. This patient doesn't have a lot of TR yet, but is likely to. And you see that this lateral annulus is barely moving up. And so the way that you measure TAPSE, if you haven't learned this yet, is you actually can throw an M-mode spike through the lateral annulus of the tricuspid valve. And if you have done, for instance, lung sliding or fetal heart rates, this is something that you can add on if you're just starting to learn how to do an apical 4, if you have echo in your department, to be able to really quickly get an estimation of global RV function and find the potential crashing patient with RV failure. We often use, to move on to some other views, this is an IVC view. We often use the IVC to look at volume responsiveness, to look at collapse, to look at low volume states. I would encourage you to think of it more as volume tolerance. The patient with the big distended IVC like this, greater than 2 centimeters, it's likely that fluids probably aren't going to help that patient, and especially when you're suspecting shock due to a right ventricular issue or an acute pulmonary afterload issue, you're likely to hurt that patient more with fluids because of that ongoing distension that we discussed. And so going back to some takeaways for how to address these issues, when we look at the centrality of RV overload and what I think is this good schematic and how it leads to ischemia, decreased RV output, and tricuspid regurgitation, and then how some of the systemic side hypotension is actually due to impaired LV inflow from that RV bulging out. We really need to do some things that might be different in reversing this spiral compared to what we might do for left-sided issues. In general, defending oxygenation and ventilation, early high-flow nasal cannula, liberal use of oxygen. High-flow nasal cannula has benefits beyond just oxygenation because it actually supports their work of breathing as well and offloads some of the respiratory load that they have that increases their metabolic rate. Defending their MAP meticulously, especially keeping it above 65, but considering higher in some states, especially with a high CVP, where you're, again, defending that RV perfusion. Sinus rhythm is critical for these patients. A common precipitant of collapse is the development of an arrhythmia, and early cardioversion can be helpful because it both restores sinus rhythm, but also isn't acting as a negative inotrope the way other antiarrhythmatics might. Avoiding fluids and avoiding intubation, I think sort of every discussion of the acute RV failure involves avoiding fluids and avoiding intubation. Avoid doesn't mean never. And so there are certainly circumstances where those are important resuscitative measures. And then particularly for your patients with pulmonary arterial hypertension, finding and identifying potentially missed or critical meds to keep them on during their stay in the emergency department and when they get inpatient is going to be important to avoid deterioration. And many of these patients are commonly on riociguat, PDE5 inhibitors, and endothelin inhibitors, but pay special attention to the patient on either inhaled or IV infusion vasodilators like treprostinil and epoprostenol, as their half-life is so short that the patient can deteriorate within minutes. And so you may hear of a patient who has an infusion pump for pulmonary hypertension, and that infusion pump going down is a true medical emergency for that person. by optimizing their volume status, we're really talking about relieving RV overload and systemic congestion and allowing that septum that's been pushed over to impinge LV inflow to move back to an area where you're allowed to have better LV inflow. And so often these patients will need diuretics. I think it's worth talking to consultants potentially, but if they have signs of systemic congestion and volume overload, diuretics are really a first-line treatment to start reducing that spiral. These patients, especially with acute RV failure, are likely to be volume intolerant or non-responsive. And markers of volume responsiveness, even such as pulse pressure variation, can actually be very misleading in these patients because they can get a reverse pulsus paradoxus. And so if you see that A-line variation, if you're able to put A-lines or have that capability in your emergency department, that could actually be quite misleading in terms of their likelihood of volume responsiveness. And I would recommend that you move early towards echo to try to see what those patients are going to need in terms of fluids or fluid removal. A caveat to this is the acute RVMI typically is not an afterload problem, and so sometimes these patients do need fluid as their RV becomes a passive conduit. But in general, the way that you are optimizing your volume status is about defending perfusion. And just like Dr. Marcolini's talk, looking at cerebral perfusion, your whole body perfusion is really dependent on your MAP minus your CVP. That is your perfusion pressure. And so as your CVP, your central venous pressure, continues to rise, you have impaired venous return, which decreases flow. And you also have an impaired diffusion gradient down your small vessels to be able to actually provide perfusion to the RV and to the systemic circulation. And so you may have a patient who's got a MAP of 65, but if their central venous pressure is 20, their perfusion pressure is only 45. And I'd ask if you'd ever accept a MAP of 45 in a patient who has a CVP of 0. Further optimization for RV performance is really about defending the RV perfusion. Keep the MAP normal, keep it greater than 65, and consider pushing it higher in those states where you're trying to get fluid off someone who has a very high central venous pressure. Supporting them not with fluids, but with norepinephrine, vasopressin as your first-line therapies, avoiding phenylephrine, which is a pure alpha agonist that can increase pulmonary afterload, decongesting their overload to, again, reduce their central venous pressure, improve their organ perfusion, and then also addressing anemia. This is a circumstance where you can consider pushing their hemoglobin potentially higher if you have that resource, or if you're in a resource-limited environment where blood may be something optimal to boost their RV performance. And then looking at inotropic support. So inotropic support, particularly in patients who have evidence of shock, who have a TAPSE of less than 10. And multiple different places do this differently. There are places that prefer dobutamine, places that prefer epinephrine or milrinone. We tend to be an early epinephrine group here, but dobutamine also works. And milrinone can be useful. It is more difficult to titrate acutely. And so if you're comfortable with that, I think it's a very good drug for acute pulmonary hypertension, for acute RV failure, but it can be a bit more difficult to titrate. Your echo is going to be key here to show treatment response. Sometimes you try one like a catecholinergic inotrope and they don't get much benefit from it, and you may have to switch to something else like milrinone. Further optimization for the RV afterload is about defending those processes we talked about before. So defending their oxygenation, assisting with their ventilation, and so early and liberal use of high flow nasal cannula is important to keep their sats up above at least 92. But your pulmonary vasoconstriction really begins at about a sat of 95, and so that's your ultimate target, to try to keep them up high. This is not a time to worry about hyperoxic injury in these patients. Metabolic acidosis has particular effects on the pulmonary vasculature. This is all something that is natural given the lungs' ability to try to get good recruitment to areas that have good aeration and blood flow. And so pH greater than 7.2 is really important for these patients, and often in the very sick ones, we will push it higher. Bicarb is controversial for a lot of reasons, but this is a circumstance where I think if you have a crashing patient, it's reasonable to use some systemic bicarb to try to boost their pH to relieve some of that acute pulmonary afterload. Just be aware that as you're giving that bicarb, you are giving a significant amount of volume, and even hypertonic bicarb pushes, so the crash cart bicarb pushes, it's actually 8.4% bicarb, which means it will recruit some additional volume. And so multiple pushes of bicarb in a volume overloaded patient can be something that's detrimental, but often one or two in a patient who's got a very low pH can be helpful to get them up above 7.2. Inhaled pulmonary vasodilators are increasingly being available. They do have a modest effect to reduce afterload. So these are things that we would commonly use in isolated RV failure, in acute afterload states like patients who've had a massive PE or a submassive PE with some evidence of RV strain. They can be given through a lot of different mechanisms. They can be given through high flow nasal cannula. They can be given through the ventilator, through non-invasive. Find out if you have them. They're not available everywhere, but if you have a neonatal ICU, a PICU, or a cardiovascular ICU in your hospital, it's likely you might have access to some of these medications. It can be a bit of a complicated setup, so before you think about employing this, if you see enough of these patients frequently, talk to some of your teams about what might be available. So avoid intubation, avoid intubation, avoid intubation. These are things we almost repeat like a mantra, but it's not really about denying intubation so much as optimizing as best you can without it to avoid that potential cardiovascular collapse in the peri-intubation period. In particular, the mediators of that collapse are the effect of positive pressure itself, but also problems that are not prepped for properly in the peri-intubation period. So hypoxia peri-intubation, hypercarbia peri-intubation, hypotension that occurs because you haven't prepared. And sometimes you have no choice. The patient with significant pneumonia who has interstitial lung disease is going to have an issue being able to maintain their ability to ventilate. The patient who's had refractory vomiting, the patient who's aspirated, who's obtunded. Sometimes those patients just have to be intubated even though you know they're at risk for cardiovascular collapse. And so when you're thinking about intubating these patients, it's really about meticulous preparation, pre-oxygenation with high flow, and I will often start these patients on BiPAP through the vent because that little bit of positive pressure you start getting gives you a sense of what their hemodynamics are going to do when the breathing tube actually goes in, and it allows you to give really good apneic oxygenation and ventilation. Pressors and inotropes primed or running, I think, is another critical feature to any peri-intubation or peri-procedural issue with these patients. Push dose can be used, but I really encourage you to have a drip up. I think increasingly peripheral pressors are being able to be used, and pressors are increasingly available even in lower resource environments. And so having those pressors going and considering pushing their MAP up to about 75, which is my practice for the really sick pulmonary hypertensives, can be very helpful to avoid that post-intubation spiral. And then dosing your medications based on their shock state. I think increasingly we think about doing ketamine low and rocuronium high because sedatives in shock states have an increased efficacy on the brain. They work more on the brain and have a lower effective dose versus your rocuronium or your paralytics that actually require the blood flow to get to that organ to have good paralysis. Avoid high PEEP, but don't allow de-recruitment, as we'll show you in another slide, and anticipate instability. You know, we talk about ECMO a lot. Increasingly, it's available in the United States at a lot of different hospitals. But think about, is your ECPR team or is your CVICU team or whoever does your cannulations available in an emergency? And then stay at the bedside for longer than you might normally post-intubation. Make sure that their perfusion is adequate. Make sure that their blood pressure is well defended. Make sure that you have appropriate end-tidal CO2 dialed in and that you have oxygen dialed appropriately to meet all of those post-intubation goals and avoid a crash. And optimal lung recruitment for these patients is really key when they're on the ventilator. We often say a low PEEP strategy or sometimes even advocating for ZEEP, but what happens as the lung collapses completely is the lung tissue itself actually is pushing on the blood vessels and causing increased afterload, and that hypoxia that comes from de-recruitment has that same process. And so what you're really looking for when you're dialing in PEEP is not a particular number, it's actually trying to get as close to a clear chest x-ray with nice smooth diaphragms as you're able with whatever physiology that patient has. And then avoiding overdistension, which causes not only increased pulmonary afterload, but also causes increased dead space and decreased efficiency of the pulmonary circulation. And so the big takeaways from this talk, which are general principles that I hope I've given you to think about how to manage these patients when you see them on your next shift or in your next time on the unit, is really about recognizing RV predominant failure, thinking about how you're going to address the causes, picking up on shock, and then defending normality, which sometimes is the best you can hope for in the absence of high quality evidence, defending your perfusion, avoiding further insults, and trying to maintain a natural airway if safe. And then planning for deterioration in your airway management strategy. But sometimes people get sicker and sicker despite your best efforts. And so think about what your resources are wherever you practice for transfer, for help, for bailout options. Because often there are teams around who deal with this problem on a daily basis. And so acute RV failure, especially at this institution, is sort of a team sport. You know, I work as part of the PERT team, and I work in some of the units where we initiate ECMO on these patients. But often there is a team around that can be helpful. In particular, if a patient is a known person with pulmonary arterial hypertension, or if you find out they're listed for transplant, there is likely someone who specializes in this area who knows them and can help you. And your biggest bailout for these patients is often mechanical circulatory support and access to specialty meds. But I think there's a lot of value in actually expertise and fresh eyes. These are complicated patients, and what to do is not entirely clear. And so having another person help give you confidence in your decision making and to help inform your care, I think is an important step in resuscitating these patients. And so with that, I just want to say thank you to the institution for putting this on, and then to some of my mentors, both within the department who've invited me to speak, and then mentors at Shock Trauma, and then Daniel Hasse for giving me some of his echo images as well. Great. Thank you.
Thanks.